Hi there, this is Dr. Tom Field, and we are going to talk about depression and bipolar disorder. We'll first look at the episodes of the mood disorders: major depressive episode, manic and hypomanic episode. We're going to explore unipolar depression, major depressive disorder, persistent depressive disorder known as dysthymia, premenstrual dysphoric disorder. We will not cover today disruptive mood dysregulation disorder. That will be saved for when we talk about disruptive behavioral problems in childhood in a later week. We will also take a look at bipolar I and II and cyclothymic disorder. From a biopsychosocial perspective, depression and bipolar disorder often have biological, psychological, and social components, particularly biological and psychological. The social is there, but it's not as prominent as, say, something like an eating disorder. With biological, there is definitely the influence of stress and volumetric loss in depression. Remember the stress response system. We've learned about the impact of cortisol secretion at high levels if it perpetuates for too long, and you see that influence on depression. Structural and functional problems and its relationship to depression, and medical conditions. We have a slide coming up about those things. You also see in bipolar disorder excessive neural activity. And most mood stabilizer medications have a goal at reducing what's called as excitatory neurotransmission, really inhibitory neurotransmission, because you can associate that with difficulty sleeping, excessive energy, excessive attention, focus, and those kinds of things. Speaking a mile a minute, those things we associate with bipolar, and it's because of neural overactivity. Okay. You also see psychological factors, especially with depression. Cognitive distortions, right? The self-derogation that can accompany depression, the glass half empty. Coping with suffering can be difficult. In general, depression is a very negative experience for people, and most people consider it to be a form of suffering, including people with bipolar disorder. And so the way in which a person navigates that is a challenge. The experience of depressive and hypomanic and manic symptoms can also be either ego-dystonic or syntonic. Dystonic meaning, if you're experiencing depression, this isn't who I am, this isn't a part of me, I reject it, right? Syntonic, this usually occurs for hypomania and mania. This is a part of who I am, I accept it as part of who I am, and it makes it quite challenging to change, particularly when, for a person with bipolar disorder, the absence of, say, the hypomania would lead to just an embracing of depressive symptoms that are low grade if they're taking, say, a mood stabilizer. That can be difficult and can lead to medication adherence issues. In terms of social impacts and factors, we have a very strong orientation towards productivity in the West, and those expectations play through in how we understand depressive symptoms and hypomanic symptoms particularly. With depressive symptoms, we often consider them very negative. In addition to being very unpleasant and distressing, we also see impacts to productivity at work, right, or to academic success. And those things are highly valued by Western society and so create more distress. You also see in bipolar disorder, hypomania being associated with increased productivity. And actually that can be a reason why bipolar disorder, especially bipolar II with hypomania, can be missed. And not always diagnosed, because the people around the person may see them as very productive during those periods and so value that. It's the crash periods that cause the problems often, the depressive periods. Depression can be caused by both endogenous, biological, and exogenous or situational factors. So what I mean by this is there can be stressors that cause depression, right? It could be divorce, or it could be bullying, or a series of things. Whereas bipolar disorder is almost always endogenous. There is a very strong genetic component to bipolar disorder. In general, medication is a component of treatment for bipolar disorder. For depression, it can be, if it's especially severe depression, and especially if it looks more like a neurobiological depression, but it's not always a part of treatment, whereas for bipolar it is. Depression is considered the #1 cause of disability worldwide by the World Health Organization. Okay, there is a large prevalence of depression, of course, And in addition to that, as I mentioned, it can be quite impairing, okay, to a person. So you need to understand that about a person experiencing depression. It's not just unpleasant, but it's also causing pretty significant impacts to their functioning, to their productivity in a world in which we value that. Major depression, bipolar, and schizophrenia are among the most common inpatient diagnoses. So you should also note for the continuum of care that you may need to consider a more acute service level for the client depending on the severity of the depression or bipolar disorder, if there are, for example, psychotic symptoms or suicidal kinds of thinking, or if the person, their manic episode is so significant that it cannot be managed outside of a hospital setting. Let's talk a bit about cortisol's role in depression to revisit something we learned about before with stress response system. I know you're like, well, didn't we already kind of talk about this? The stress response system is so crucial to understanding anxiety and depression. So it comes up again and again. There is a very strong cadre of evidence that an overactive, especially sympathetic branch of the nervous system, right, too much cortisol being secreted through the HPA axis, is associated with depression. HPA axis dysregulation of major depression is, and I quote, the most consistent and robust biological finding in psychiatry to date. Okay? An estimated 50% of major depressive episodes is linked to chronic stress and HPA hyperactivity. In children, chronic stress is a risk factor for subsequent first episodes of depression. And methylation of CRH genes, you may remember this is what's sent by the hypothalamus to the pituitary gland to initiate the HPA axis, okay, is associated with suicide attempts in adolescence. Okay? So, all told, stress plays a major role in depression, okay, and we should be therefore trying to do two things. A, try to reduce stress in a person's life, and considering advocacy for that, especially if it's systemic forms of stress that we've talked about before. And also engage in things like stress reduction, right? Trying to help a person engage the parasympathetic system, deep breathing matters, in addition to basic coping skills. I don't know why I have one single slide on this, but very quickly, volumetric changes are often corrected through neurogenesis of neurons and glial cells, meaning that it is possible to change these things, right? That if you see volumetric decline, especially in the hippocampus, which occurs during depression, the memory system can be impacted. It is correctable if a person is able to work through it. I will say here that you might wonder, well, how do you correct volumetric decline? One of the very interesting things that we found over time is that counseling makes a bit of a difference, but what makes a huge difference is sleep and exercise. And so, especially with anxiety and depression, those lifestyle habits play a major role. And in intake, you should absolutely be asking about that, about how many hours of sleep a person gets a night, the quality of sleep, their exercise routine. If it isn't on point, it would be worth addressing because it can make a big difference to depression. There are other medical conditions also associated with depression. Major depression has been associated with head injury and stroke, hypothyroidism or low amounts of thyroid. And by the way, this cortisol has a role here too. Increased cortisol is associated with reductions in thyroid stimulating hormone. And vitamin D deficiency, right? So all of those are medical things that need to be evaluated. Thyroid levels, vitamin D levels are things that should be evaluated early on in treatment for all clients through things like a basic physical exam with labs. I think doing that early in treatment is important if they can do that within a couple of weeks of initiating counseling, because you want to make sure, especially if they have depressive symptoms or anxiety-based symptoms, that those issues are ruled out, so that you're not just dealing with a medical problem through mental health means, which is not going to be successful. In terms of the mood disorder spectrum, and this is a way to try to explain to you A, severity, and B, like the relationship between all of these episodes. Okay, so this is something I've created to help explain all of this. We have to begin on the left-hand side with episodic minor depression, and the right-hand side is the most severe, major depressive episode plus manic episode. Okay, so on the left-hand side, we'll start with least severe. Episodic minor depression, episodic meaning it happens occasionally, it doesn't last for that long particularly, or it may be cyclical with premenstrual dysphoric disorder, that it happens every month. So it's minor depression, doesn't meet the criteria for major depression. Okay. Then we have minor depression plus minor hypomanic episode. This is called cyclothymia. So what is that? Basically, in cyclothymia, you have minor depression that does not meet threshold for major depression. Plus, you have minor hypomanic episode, which does not meet criteria for depression. Okay, so that's cyclothymia. More severe than that is major depressive episode only, major depression. This is major depressive disorder. I'll note here that if a person has major depression or minor depression for more than 2 years duration, it's diagnosed as persistent depressive disorder. You can have persistent depressive disorder and major depression concurrently. I would say persistent depression probably is in the same category as maybe actually cyclothymia than major depression, not quite as severe. Major depression is considered a more severe diagnosis in general than persistent depressive disorder. Then we have major depressive episode plus hypomanic episode. This is known as bipolar II. Note that you need both a major depressive episode and a hypomanic episode for bipolar II. For bipolar I, the most severe, you only need a manic episode. You could also have a major depressive episode, but only a manic episode is required for a bipolar I diagnosis. So let's take a look at the major depressive episode. This is defined as, and I've talked about the 5 of 9 before, and I'm referring to this slide here when I've said that before. 5 of the following 9 symptoms in a 14-day, 2-week period must be at least 2 weeks. Many of you have probably had some of these symptoms, maybe even 5 of 9, but they've only lasted a week. That does not meet criteria. It must be at least 2 weeks. Okay. Most of the day, nearly every day. Depressed mood, loss of interest or pleasure in activities. And that, by the way, is called anhedonia. Significant change in weight or appetite could be greater weight or less weight. Change in sleep could be sleeping more, hypersomnolence or less. Not as much sleep, impaired sleep. And those two, by the way, 3 and 4, are considered the neurobiological aspect of depression, sometimes called vegetative symptoms. Motor agitation or hypoactivation. Most often you see hypoactivation. Agitation is less common. And you usually see that in children, I would say, more often than adults. It can occur, but it's less common. Fatigue or loss of energy. Note that this symptom, as well as symptom 8, difficulty concentrating, are both symptoms as well of generalized anxiety disorder. And so there is often a concurrence between these two and also a need to differentiate them in diagnosis. Worthlessness or excessive guilt. This is where you get some of the self-talk stuff, the self-derogation. Recurrent thoughts of death and suicidal ideation last. Note that this is important as a symptom. If a client experiences any depressive symptoms during an intake session or subsequent sessions, you should be asking about suicidal thoughts. It's important to rule that out, okay, and to be monitoring it. I will also note that you do not have to have it for a major depressive episode because you only need 5 of 9 symptoms. So you could have 5 of the other symptoms and you do not need suicidal ideation to meet criteria. Okay? The symptoms have to cause distress or impairment. They almost always do. And not attributed to a substance or medical condition. If it was a substance-induced depression, such as long-term alcohol use, for example, you would code that differently. It would read as substance-induced depression. There's another code for that. Okay, the coding of major depressive disorder. This has to be not better explained by a psychotic disorder, and we will talk about the relationship between major depression and psychosis. Let me very quickly give you a sense of that in the next slide in the coding chart. No history of manic or hypomanic episodes. If there's any history of that, it cannot be major depressive disorder. We'll also talk about that in a minute, that it can be quite controversial. Any history of mania or hypomania means a bipolar diagnosis, even if every other episode subsequently is depressed. Cyclothymic disorder is sub-threshold symptoms of major depression and hypomania that last for at least 2 years, 1 year in a child or an adolescent. Okay, so long-standing symptoms, but note that they do not meet threshold for either major depression or hypomania. Okay, and there is no history of major depression, of mania, or hypomania. If there is, you would diagnose it as one of the others. Okay. Persistent depressive disorder. This does not meet the does not need to meet the threshold for a major depressive episode, but it can. It has to be at least 2 years of symptoms. You can also have, as I mentioned before, 2 of diagnosis, both persistent depression that's lasted 2 years and a very kind of uh, acute, like recent major depressive episode. That would be probably captured as persistent depression and major depression. There can be no history of hypomanic episodes here, like cyclothymia. It's a sub-threshold deal in terms of major depression and hypomania. It used to be called dysthymia. Here is the coding chart. There is a different code for single versus recurrent episode, and the severity mild, moderate, and severe gets its own code. Note the specifier with psychotic features. Okay. Now, there is a relationship between mood and schizophrenia and psychotic spectrum problems. What I will say here is, and we'll explore it much more next week, that if a person experiences, let's say, an auditory hallucination, like they hear voices, but only during the mood episode, only when depressed, and the voice disappears when not depressed, okay, that would be coded as major depressive disorder with psychotic features. However, if they hear the voice outside of the mood episode when they are not depressed, it is going to be diagnosed as either schizoaffective disorder or schizophrenia, and we'll talk about how to differentiate those next week. On the mental status exam, what are the potential signs of depression? You're looking physiologically for low energy, typically, reduced motor movement. Agitation can occur, of course, but low energy is very typical. Monotone speech at times. Behaviorally, withdrawal from others is common. You can also see some compensatory behaviors around depression, such as substance use. Cognitive, you're looking at catastrophizing, right? Some of those negative self-talk pieces, pessimism, hopelessness, helplessness. And then emotional, tearfulness, also a blunted affect is common, sad affect, and can also be irritable. Bereavement can mimic depression and should be differentiated from depression. There is a bereavement exclusion in the DSM-5. The quote is, "In grief, self-esteem is preserved," meaning to meet the criteria for major depression in grief, self-esteem would have to tank. And so you would look for self-derogation and perceived failings there, such as a quote that the client may say might go something like, "It's all my fault that this person died. I wish that it would be me rather than them, and I'm a worthless person now." Right? They would make these statements about worthlessness and such. And if they do have death wishes, it's not just about wanting to join the deceased. I wish I was with them, right? It's more about I'm worthless and I deserve to die, right? A darker kind of tone. Okay, depression versus bipolar disorder. How do we differentiate those? So let's talk first about prognosis. Bipolar disorder is considered a chronic and persisting disorder and has high recurrence. Manic episodes have a 60 to 90% likelihood of recurrence. It's part of the reason why if you have a manic episode, you're always going to be diagnosed with bipolar disorder. Major depression has a better prognosis for recovery, 40% to recover in 3 months, 80% in 12 months. It means only 20% do not recover in a year. Okay? Premenstrual dysphoric disorder tends to be more chronic and persisting, ongoing, because of the monthly cycles. I'm going to mention some diagnostic caution here around this. I mentioned that if you're diagnosed with a manic or hypomanic episode, you will always be diagnosed with bipolar disorder, even if all subsequent episodes are depressed only. Okay? So because of this, you just want to be cautious. If you are not sure if they have hypomania or mania, and to be honest with you, you probably will be sure because the symptoms are so severe. But if you're not sure, then you should be cautious, right? Because you are making a lifetime diagnosis for a person. Let's talk about the manic episode first, and then we'll look at hypomania. A manic episode is at least 7 days of, and this mood is very important to pick apart, elevated, that means euphoric, expansive, that means like grandiose, like on top of the world, I can do anything. My ideas are amazing, fantastic, the best ever. Irritable, tends to be an edginess for some clients. And also increased energy and activity. Do you remember neural activity is really overcharged, if you will, during bipolar. Most of the day, nearly every day, and you need 3 of 7. Okay, must have 3 of 7. Inflated self-esteem or grandiosity. Decreased need for sleep, rested in less than 3 hours. Some clients don't sleep for days on end. More talkative than usual with pressured speech, difficult to interrupt. Flight of ideas or racing thoughts. Distractibility, their attention wanes, right? It's hard for them to focus. Apart from when they're on a specific activity that is something they're trying to accomplish, then they have increased goal-directed activity and even agitation when interrupted from it. They also may engage in excessive activities associated with painful consequences, such as spending sprees, sexual indiscretions, and foolish business investments. Okay. These symptoms indicate a change in mood or functioning that are uncharacteristic and observable by others, meaning other people can notice, wow, you are quite different from how I've seen you in the past. Okay. And it often will perturb others. They'll be worried about a person. It can also push people away. Mania tends to be something that really is, it doesn't attract people to you, makes people concerned about you. And severe impairment can occur that can cause things like psychosis and hospitalization. Okay? Anytime there's psychosis, by the way, the period of 7 days, I believe, is waived. Anytime there's hospitalization, it's waived. Okay, so that's the manic episode. Now, what's interesting is if you read the DSM-5, hypomania is exactly the same. The symptoms are exactly the same. Symptom list, 3 of the 7 is the same. It's only 4 days rather than 7. Okay. The only difference really that's described other than the time period is that the impairment is less severe. No psychotic features or impairment resulting in hospitalization. It doesn't sound that different, but I will tell you in clinical practice it is very different, and I'll describe that to you next. Okay, so what is the difference? The level of functioning is different. This is the way to think about it. In mania, the quality of work output or activity output is impaired. The quality of output is impaired. Okay, I'll give you a clinical example to explain this. I once worked with a 17-year-old who was a linebacker and was also someone who loved to paint and would paint in his parents' basement almost every night. One evening, his parents went upstairs. He was still painting. They came downstairs the next morning. He was still painting in the basement, had not gone to sleep. And here's what they noticed about the quality of his painting. Okay, he was a very detailed artist. You know, he had a fine eye, right? He was quite a detailed painter. His paintings were big swirls, like you would see from a 3 or a 4-year-old. Right? No real detail to them. And there were hundreds of these paintings like this, big swirls all over the canvas. Okay, all over whatever he was painting on. And so he was brought into the inpatient unit, and he was also not speaking in a coherent fashion. So that it feels very different than, so I want you to also imagine someone who works, let's say, 16 hours a day. Either they're writing a book, a novel, or they're doing work as a lawyer, let's say, in the legal field, and they're just cranking out the work. But the quality of the output is still great, right? That would be more akin to bipolar II disorder. So in bipolar I, you see an impairment in output, whereas bipolar II, you do not tend to see an impairment in output, in my experience. Okay. I'll also note here that while mania will push people away, hypomania can actually be attractive to people because a person can be ebullient, top of the world, fun to be around, whereas mania tends to be, frightening to people, especially if there's psychosis involved. The bipolar II depressed phase can also last longer than bipolar I. It's important to note that. Not for all clients, but for some clients it can. I'll also note here that most clients are going to come to you for therapy during their depressive episode, not hypomanic or manic episode. Okay, manic episode they wouldn't, because usually they can't make those types of decisions. They tend to, be fairly impaired. But with hypomania, a person isn't going to see themselves as having problems. They're on top of the world, right? They're getting a lot done. Whereas with depression, it's a very unpleasant experience, and that's why you see persons seeking therapy. Here are some visual depictions of the two mood phases in Bipolar I and II. In Bipolar I, what you see is the person reaches a point of mania. In the red, you can see it there. Note the depression is longer than the mania. If you see the depression on the left-hand side compared to the right, it lasts longer, okay? And it is not true that in general that a person goes straight from depression to mania. Usually there's a period in between where they maybe have just a slightly down or normal kind of mood, and then eventually they have the period of mania, okay? That's how the way the cycle works. This cycle typically is going to take weeks to months to occur. People do not tend to cycle between this in a period of days. And in fact, if you have a client who's cycling between these mood episodes, let's say in a matter of a day, they're looking more like they probably have borderline personality than bipolar disorder. Okay, because even rapid cycling forms of bipolar is like 4 or more of these changes in a year, okay, of these episodes. Okay, Bipolar II, you see that the extent of the mood elevation is nowhere near as significant as Bipolar I. There's hypomania there, but there's not mania. You'll also note there that the mood episode actually it doesn't last. I'm sorry, I repair myself from before. It does not last as long as Bipolar I, the depression, typically. And it's usually about the same severity, it just doesn't last as long. A person with Bipolar II tends to have longer periods in between episodes as well. Okay, so the diagnoses, Bipolar I, must have met the criteria for a manic episode, may also have occurrences of major depressive episodes and hypomania, and there's different coding for that. Bipolar II must have met the criteria for both hypomania and major depressive episode, both. Must not have experienced a manic episode. If they do ever experience a manic episode, it will forever be bipolar I disorder. This is the way the coding chart would look for bipolar I disorder. You can have current episode hypomanic, right, or depressed or whatever, but if they've ever experienced mania, it has to be bipolar I, and you would code it by the current episode that they're in. Note that you also have with psychotic features there listed. And it works very similar to depression, as I mentioned earlier, that it can only occur during the mood episode for it to be listed as bipolar disorder I with psychotic features. Okay, on the mental status exam, what are the potential signs of mania or hypomania? Usually it's pretty apparent. These symptoms are pretty intense and obvious, and so usually you know that there's something up with the client if they present with mania or hypomania in your office. They are going to have difficulties falling asleep physiologically. They are going to have high energy, restlessness, maybe even agitation in their motor movement, pressured speech and racing thoughts. Behaviorally, they are going to be driven for task completion. They may engage in risk-taking behavior. There may be substance use involved. Cognitively, they may be thinking about themselves in an overly, grandiose fashion. They may be distractible. They may have difficulty concentrating. They may also be self-absorbed. That can occur as well, especially in intense mania. Emotionally, an intense affect is common. They are either going to be jubilant and elated or edgy and irritable. The mood, again, does not tend to change quickly as you would see in borderline personality. For example, it wouldn't change from that to depressed quickly. Okay? And psychosis in mania only. Okay, I'm going to share with you some key symptoms of bipolar disorder here. Pressured speech.
So how was your week?
Oh, my week was really stressful. We have this big safety inspection coming up at work, and it's been a lot of pressure, and honestly I've been kind of overwhelmed because we have to audit all of our files, and we have to check all the machines to make sure that they're working and make sure everybody's training is up to date, and not everybody's trained, and frankly some of these people, it's just going to be really hard to get them up to speed. It's just going to be really difficult, and some of our files are out of order, so we're having to have interns work on that, and trying to coordinate all these people is just a humongous mess. I mean, it's just such a mess. But I'm hoping that we'll do okay on the inspection, since we did okay last year and the year before. But 3 years ago was a different story because we had a different manager, and he didn't really keep track of things, and some of the machines weren't working when they came, so we had to get that up to speed. But really the last couple of years we've been up on that, and we bought the new machines that we needed to buy. So now it's just a matter of getting the people up to speed, and that's kind of what I'm in charge of, is kind of coordinating the whole thing.
So going back a second, if we could go,
it's just difficult when you have these
we could
people
go
that are
back
not
to
very
your
well
week.
trained, and they're they don't have a whole lot of education.
Well, hold on a second. Let's go back.
And like just having to plan the trainings for all of these people.
Could we go back a second?
You get there the sense of this person having a lot to say and speaking in a fairly quick pace, and also in a way that's difficult to interrupt. Next, let's look at the symptom of grandiosity.
So the other night, I had this like amazing idea. I mean, it was just like the best idea I've ever had. I mean, I just felt like I was just so like in tune with everything, like just like the creativity of the universe was just like flowing through me right then. And I stayed up like all night working on this idea, and it's going to be totally awesome. It was like this board game, and it's going to be totally like to do with these like principles of economics, and it's going to be amazing. Like I already know, like it's going to be like I'm going to make it. Like I'm going to do this, and it's going to be like this humongous hit. Like it is going to be a top board game. And like I've just never seen anything like it. I mean, Monopoly, like complete and utter crap compared to my idea.
Wow. So you get a sense for the intensity of affect there, right? The person is really sold on their idea, and there's nothing you can do to talk them out of that, right? Or suggest otherwise. And that's the type of thing you're looking for with grandiosity. With bipolar disorder, is that edginess. And the grandiosity, of course, is around, this is the best idea that I've ever had. It's an amazing idea. It's better than other ideas. Monopoly is complete garbage compared to my idea. Okay, premenstrual dysphoric disorder. This is mood symptoms that usually occur in the week before menses, improve during menses, and are minimal after menses. Okay. The symptoms are things that women typically experience, but the main thing to focus on here is that it would be considered like distressing above and beyond what most women would experience. So the symptoms include mood lability, irritability and interpersonal conflicts, depressed mood, hopelessness, self-deprecation, anxiety or tension, anhedonia, difficulty concentrating, lack of energy, change in appetite or sleep, feeling overwhelmed and out of control, and physical symptoms such as breast tenderness and bloating. They need to have 2 symptomatic cycles in order to qualify. Now, I know what you're thinking, which is, why is this a diagnosis, right? This is just something that most biological sex females experience. And my response to that is, that's true, and you certainly could make an argument that there are a lot of social and cultural reasons why this is in the DSM. I will say from clinical experience, though, that I have met people who do indeed have more significant symptoms than would be typically experienced by most women, and do meet the criteria for depression, more broadly writ, only during that week. And so for those people, this makes a lot of sense. I will also add that they're creating specific hormonal treatments for this now that are very helpful to people who experience this. Mood disorders have specifiers that you should be aware of, and it's worth reading these in the DSM. With anxious distress, as you might imagine, this is like the anxious symptoms are exacerbated in depression. Rapid cycling, remember that's not what you think it is. It's still 4 or more episodes in a year. It's not changing every single day. Mixed features. A mixed feature occurs when a person has things like a crossover between depressed episode and manic episode, or hypomanic episode. So they may, for example, not be sleeping, but they also have depressed mood, and they may be more productive than usual. So they have like these mixed features in between episodes. Melancholic features, atypical features, mood congruent and incongruent features, psychotic features. Catatonia, peripartum onset. This used to be called postpartum. It's now called peripartum to capture the entire kind of time around pregnancy and delivery. And then seasonal pattern, so what used to be called seasonal affective disorder. So those are all worth reading about and becoming familiar with. So prevention, what do we do? Psychoeducation on healthy eating, sleep, and exercise is very important. As we've talked about before, a person's lifestyle habits, particularly sleep and exercise, are very important to mitigating things like depression and anxiety. Being aware of your mood cycles and your triggers, your antecedents for a mood shift is important with bipolar disorder, and mood tracking can be very important. And what you do with that is you're tracking every day what your mood is to try to get a sense of, what the signs are that you're about to have a shift in mood. Medication adherence can be helpful, particularly for bipolar disorder, and can be a challenge, as we've talked about. The impact of substance use, this is worth absolutely addressing. Body awareness, especially within people who have, I would say, more of a physiological activation, more irritability and such during depression and bipolar disorder. Mindfulness is a very powerful technique, right, of just being able to accept experience, because remember, if the suffering associated with depression can be very difficult for people to sit with. Relapse prevention, wellness recovery action plans, and lists of support people. For bipolar disorder, in terms of treatment planning, what we would do in session to kind of address this. We are going to need to coordinate with medical professionals. They may need an inpatient service level if they have active mania. We also, again, work on tracking mood cycles to manage the condition. Okay. With depression, most approaches work in counseling, and we actually have a lot of different options, and we can select based on the presentation. For example, is the major problem, and this gets back to the symptom level of the RDoC we've talked about before, is the problem that they are intropunitive and they have low self-esteem, in which case maybe we want more of a cognitive approach, cognitive behavioral approach. Is the problem low energy? Maybe they need behavioral activation. Is the problem isolation? And they need maybe something like interpersonal psychotherapy. Is the problem grief and loss? And maybe they need existential therapy, and for existential issues, existential therapy. Are they trapped between two choices? And maybe something like Gestalt therapy could be indicated. There's a lot of different approaches to depression, depending on what the stressor is, if there's any antecedent, as well as the types of symptoms they're experiencing. In conclusion, depression is typically an ego-dystonic experience that is disliked by almost all who experience it. It is the #1 cause of disability, according to the World Health Organization. Distress and impairment often accompany it. Mania and hypomania can be egosyntonic. They may not be perceived as problems by the person experiencing it, though other people around them will identify it as a problem. Sleep can be strongly impacted by both, and note the role of serotonin there. You can have hypersomnolence, too much sleep, hyposomnolence, too little sleep. Okay? Particularly too little sleep in bipolar disorder. You don't tend to see hypersomnolence in bipolar disorder, too much sleep. Depression can be situational or environmental, whereas bipolar disorder seems to have genetic influences, and that has meaning for the typical treatment approach and the use of medication. It's worth carefully studying the diagnostic criteria for major depression and manic episodes, and to get a sense for how a person meets criteria of those. I'll mention this because your licensure exam will require you to know this very well, and so it's worth memorizing the 5 of 9 symptoms of major depression and the 7 symptoms of mania. It's worth memorizing them. You will also need to be able to identify them in treatment settings often, so it's worth learning these. Note the differences between bipolar I and II, which aren't well articulated in the DSM, such as the difference in the overall quality of output of their work. And finally, medication playing a role in treatment, especially bipolar disorder and severe forms of depression. And that wraps this video lecture.